tailored, individualized to each patient. And therefore, actually, the IDEC took a step in 2012 on individualization. And that's first matrix on individualization. And they said appropriate or inappropriate action depends on attitude, treatment efforts, hypoglycemia, disease duration, life expectancy, comorbidities, vascular complications, and resources. So somebody is motivated, no hypoglycemia, newly diagnosed, long life expectancy, no comorbidities or vascular complications, and can afford, be aggressive, go at 6.5 or 6 or 5.8. But somebody has lack of adherence, recurrent hypoglycemia, long-standing disease, limited life expectancy, lot of comorbidities, lot of complications, you can go easily even at 7.5. That's what has happened. So obviously, if you look at the level of evidence for cell, it's level of evidence B, and it's reasonable goal for most non-pregnant adults. If you look at 6.5 as a goal, it's predominantly level of evidence B for long duration, where you need to move it to 7.5. So short duration, long life expectancy, and low cardiovascular disease, 6.5. Level of evidence B, 7 is for reasonable for most non-pregnant adults, but when you go up to 7.5, long-standing disease, recurrent severe hypoglycemia which can be life-threatening, limited life expectancy, advanced microvascular complications, or extensive comorbid conditions, level of evidence C. So that's exactly where the level of evidence stands when you individualize an A1C target, whether it's 6.5, 7 or 7.5. And this was Itimad Razgari summarized this whole article on personalized A1C targets in individual type 2 diabetes. And that's what he talked in his article: short life expectancy, long disease duration, frail patients, comorbidities, advanced diabetes complications, personal preferences. But he also looked at psychiatric issues, cognitive dysfunction, social and educational issues, drug tolerance, drug access. And therefore, they amended a target from 7% to 7.5 to 8.5. This is what is an amended target. And that's not what we discussed in our meetings. In our meetings, all the time in the next 2-3 days, we hear 7. Remember, it could be 7.5 in the level of evidence C, and it could be an amended target for a small cohort of type 2 diabetic patients where somebody could be frail, long-standing disease, short life expectancy, where you can have an amended target of 7.5 and 8.5. It's evidence-based, it's 88 hours. So obviously, when you look at personalized therapy for a co-management approach, primary care and concurrent diabetes management specialty therapy, the personalized targets or algorithms can be different. Okay, who do we really want to prefer to specialized targets? When you're looking at unusual variants like the LARA movie, somebody with heavy proteinuria, somebody has recurrent hypoglycemia, is not achieving glycemic targets, not responding to therapy, has not of drug intolerance or contraindications, or has recurrent hyperglycemia. So the other way of looking at therapy is somebody is symptomatic. How can the approach be personalized? Look at the age, look at the abdominal risk, look at symptoms, right? Look at coincidence. You will have two classes: beta cell defect and insulin resistance. The dual diseases. Look at IDEC antibodies. If there is insulin deficiency with the C-peptide or insulin resistance for pro-insulin mutations. And you may have four subtypes. The insulin resistant is diabetes obese, the non-obese, non-insulin deficient diabetes, and the other. And you need to recognize that you can have different options for all these different conditions. So it is not as simple as it appears, and you can have your crop of treatment options which you can do. The other thing is genomics. You know that when you look at genes, 99.6% of our genes are identical. We only have 0.4% of our genes which are unique, and that can differentiate somebody short, somebody tall. You can see that in that picture. And this was supposed to be 10 years back, the breakthrough of the year in genomic mapping. And therefore, most genetic variations are shared by us all, 99.6%. Compared to chromosomes, from any two people, only 1 in 1,000 bases differ. That's all, if you really look at that. And therefore, do these same sites show variation in other people? And 90% chance is that they do. And that's the frequency. So if you look at it, we are 99.6% identical from the genetic standpoint. It's only 0.4% that will differ, and in that 0.4%, you do get those variations. So obviously, we know a lot about human genomes, but you remember that all single gene diseases are only 2,000. And when it comes to heart disease, diabetes, cancer, obesity, they are polygenic or multigenic diseases. The single gene diseases are rare diseases, and obviously the large non-communicable diseases have a different approach on public health. The other thing which we learn from genomics is many differences in the way individuals respond to different drugs. Because we know that somebody will respond to metformin, somebody will be intolerant to metformin, somebody will get edema or heart failure with prednisone, somebody will not. And that is pharmacogenomics. So there is a lot of pharmacogenomics in type 2 diabetes drugs. For example, somebody gets metformin diarrhea or gets intolerance to metformin, it's clearly a modulated gene called OCT1, organic cation transporter 1. If somebody gets even with 0.5 milligram of glimepiride, hypoglycemic, it is nothing but the cassette, ABC cassette of C8 or KCHA11, which is abnormal. And therefore, that cassette transporter ATP binding is abnormal. That's why we get a triggered hypoglycemia. Somebody puts on a lot of weight or edema with a glitazone, which is triggered lipoprotein lipase gene or pipa-gamma gene. And similarly, in fact, we see some patients with gliptins don't respond to gliptins at all, because there is a GLP receptor polymorphism with them. And some people, even with 5 units of insulin, get severe hypoglycemia. And somebody will get 200 units of insulin and not even get glucose coming down by 10 points. And that is linked to insulin receptor gene. So obviously, there is a lot of pharmacogenomics involved. The most typical well studied is the OCT1 SNP of metformin renal clearance. And therefore, some people can even respond to metformin very well in this case. From the Indian standpoint, do Indians need a lower dose? Do they respond better to lower dose? Are there any variations? Do we have gene polymorphisms? The answer is we really don't know, but we know for sure in Indians. We are carbohydrate rich. We respond better to alpha glucoside inhibitors like Chinese. We have altered glucagon response and different glucagon integrated pathophysiology because we have higher carbo on our diets. So Indians are unique because we have diverse clinical phenotype, different manifestations, we have cost complications, excess adherence issues. So we are definitely different. But a particular student, Kale scored very clearly a couple of years back, we published in JAPI, that 7.5 or 15 milligrams students with bioconazole can do very well on A1C reduction without causing any weight gain. And that's why you can use low dose of prednisone. The synthetic registration trial from Asia, India and Korea showed that the drop of A1C is not 0.5, 0.6, it's 1.36 based on the carb load. So obviously we are different because we are a carbohydrate country. The STAR study which we clearly showed that we have East India, Central India, West India, North India, South India, we eat carbs, carbs and carbs, and a lot of fat and no proteins. So obviously when you look at how personalized diabetes care will be different, who will respond? We will have genotype 1. And we will have in a single 0.5 ml of blood, blinded genotype, unblinded genotype, and get outcomes, whether it's weight, whether it's A1C, whether it's safety, tolerability, lipids. And actually this can be done. So remember, whenever we treat a patient with type 2 diabetes, if you look at a personalized omics approach, only 40% of our patients, the treatment is effective or safe. 20% is effective but with side effects. 20% is ineffective without side effects. 20% is ineffective with side effects. You can have a simple gene chip where you can actually pick up who will respond, who will not respond, who will get a side effect, who will not get a side effect, and the LI is not very far off. So that was as far as the genomic standpoint is concerned in personalized diabetes. But we are moving, the biggest drawback to us is nutrition. You must have seen the WhatsApp circulating now that diabetics can eat mangoes. And that created havoc with a lot of our patients. Because we are in the era of molecular and transcultural nutrition. And obviously nowadays people look at a molecular nutrition protocol. We need to see that a given individual will have a different pathway for proteins, for nutrients, for dishes, for meals, for metrics, and their feedbacks. And therefore, if you look at the food selection and the meal plans and the clinical parameters, you will have a different foodome and metabolome interaction. You are a symposium of gut microbiome. But clearly, in cardiometabolic disease today, we clearly look at foodome and metabolic interactions. Based on the religion, the culture, different types of foods in different countries respond differently. So we have a patient, typical patient, 43-year-old female, 78 kilograms, 165 centimeters, type 2 diabetes for 4 years, A1C 8.3, blood pressure is elevated, LDL cholesterol is high, HDL is low, knee pain, reduced mobility, metformin for 3 years, current dose twice a day. We have a lot of options. You can use glucagon, glycine, glitazone, the AGI, gluten, SGLT2. Some people may say, somebody will say, orlistat, or we could also modify that. So obviously, in this particular patient, we don't need a clean chip. We don't need any of those genomics which I told you. We just need to understand the transculturalization of nutrition better. But remember, when you compare Caucasians with South Asians, Chinese, the area under the curve of Indians is larger post-pandemic. That has been consistently demonstrated by different workers. We also have a different need. Our non-exercise activity thermogenesis from an agrarian Indian to a sedentary Indian has dropped down from 2000 to 700 kilocalories. So obviously we need to really transculturalize our approach to diabetes from the lifestyle standpoint. We need to give culturally sensitive approach for healthy eating habits, looking at local custom-made foods for a specialized diet and lifestyle adherence plan. So that is all about transculturalization. So what are the transcultural factors which impact personalized diabetes care? Not only just medical resources and dietary patterns and food resources and taste, but also economics, food balance, policy and efficiencies. So obviously diabetes-specific nutrition algorithms and transcultural program for optimizing diabetes care and pre-diabetes care has been a passion with many workers across the world. Osama Hamdi from Harvard and Jeffrey McCanny from Mount Sinai have been leading that. And they developed an algorithm. It's a very straightforward algorithm. Look at the ethno-cultural lifestyle food, because from every geography of the world, the lifestyle differs. Look at individualized risk stratification, whether it's family history, anthropometrics, oxology, blood pressure, dyslipidemia, cardiovascular event, liver disease, microalbuminuria, and then class them as high risk, low risk, give general recommendations for lifestyle, look at overweight, blood pressure, and lipids, and follow them up, add more of across the board. We know our BMI cut points in Asians are different. We know our waist circumference are different. Our BMI cut points are different. And obviously our physical activity patterns are different. Dr. Atul Mishra very clearly has given guidance for Indian patients, where we have been able to say that we have modified our patterns in a different way. And then of course we need to use glycemia targeted specialized nutrition approaches. We have bariatric surgery coming up, we have DASH diet, we have glycemic index coming up. So when you look at Indian transculturalization, we are sarcopenic. So we need to improve our proteins. We need to do physical activity with muscle building. We have challenges with adherence issues. We have religious fasting issues. We have power. We have to produce rice. We need to encourage lower glycemic index and more fiber foods. And we need to recognize our cooking method. These are really our problems with transculturization and individualization. We need to recognize them better. And we need to have an Indian approach to that. One of us talked sometime back on that. PDN algorithm for India. And I don't want to go into details for brevity of time. But obviously, across different Asian countries, whether it's calorie consumption, carb recommendations, protein, fat, fiber, sodium, these recommendations are very variant from Taiwan, China, Hong Kong, India, Malaysia compared to the area recommendations. So obviously we need to recognize that from our part of the world, we are sedentary with high intake of fast food. We have family gatherings, huge banquets, massive calorie loads. We need to really move, because we have moved from small lean meals to large energy dense foods. We need a lot of high glycemic index to give short grain rice. We have transitioned our dietary patterns, sedentary lifestyle, 50 phenotype, urbanization, and we have festivities and holidays. We have a hectic lifestyle. We frequently snack energy dense foods, and obviously we need to move that to whole grain cereals and so on and so on. And obviously we need to have better exercise recommendations. We need to have more aggressive lifestyle approaches. And obviously these things we need to recognize. So obviously what I want to do and tell you, that personalized diabetes care is not just about individualizing. It is integrating a given geography, looking at socio-cultural input and integrating that with your day-to-day life. Also remember, we have a huge area called pharmacogenomics which are highlighted. For example, we know that Indian patients respond different to glutens, different to gluten-based therapies. They have a difference in response to glutazones, which do very well in our phenotype. So we need to match phenotype remember the dimension of diabetes is very huge. Lifestyle medicine is very integral in diabetes comprehensive plan. We need to have evidence-based recommendations, not directly postponed to global targets. I told you even for A1C targets, someone's amendable A1C target might be 7.5. For somebody it could be 6.5. And for a third individual it could be 7. 7 is also an arbitrary cut point. Remember, the 7 and 6.5 are all based on level of evidence is B. We still don't have level of evidence as A. These are arbitrary cutoffs put out by various societies, but they still don't have a robust evidence base of level of A. And the 7.5 cut point for people with short limited life expectancy is having a level of evidence of C. So when you are looking at that, we need to be very, very sensitive of the type of evidence which we are looking at. Also remember, we are living in an era of trans-cultural algorithms. These are good tools, but they need validation with RCTs. So obviously, personalized medicine has an impact. We need to shift emphasis of medicine from a reaction to prevention. We need to direct selection of optimal therapy and reduce our trial and error strategy. We need to avoid a lot of adverse drug reactions. We need to improve patient adherence, quality of life, and we also need to ensure that the right drug for the right patient at the right time is given. And obviously, can impact overall health. So, what should be a practical approach for an Indian patient, for example? Dr. Mishra again had his guidelines, these are published now. For an Indian patient, we have a challenge with BMI and how he presents to us. With the A1C about 9%. So, somebody's BMI is more than 23 and A1C is more than 9%. Probably the approach is insulin. But we have individuals within India whose BMI will be between 20 and 23. And they can come with ketosis, infections, or a major comorbidity. Obviously, we still need to give them insulin. But we also see patients within India who present with type 2 diabetes with the BMI less than 20. And obviously, they need insulin on board right away. So we see a BMI, we see a A1C, and you need to recognize ketosis, infections, and comorbidities as a part of your personalized algorithm. Also remember that all guidelines across the world, mainly from Europe and US, do not consider AGIs. But we are a car country just like China, and therefore in our second line of treatment, we need to integrate the alpha glucoside inhibitors. So all I wanted to highlight is personalized diabetes care is all about individualization. Anyway, type 2 diabetes is a heterogeneous disease, and we need to ensure that we individualize our diabetes care, and that is the current trend. We need to generate a lot of evidence base for individualized care. The current era is not yet modernized to have a gene chip, tell who will respond, who will not respond, but definitely we can tailor our therapies so that we can titrate, so that we can get better A1C goals and can get better outcomes for our patients. Thank you for your patience.
Thank you very much, Shashank, for that beautifully delivered first plenary of our IDEC 2017. We do have time for a few questions. This is a very interesting area of personalized diabetes management. So if there are any questions, we have 5 minutes and we can have a good interaction with Dr. Shashank Joshi. So if any questions are there, please.
Sir, I'm interested to know about anywhere in the world, before giving the antidiabetic, that genomics is done, like metformin, who will respond better and who will have side effects, and for DPP4 basically impractical, or these are all for research based?
Currently, they are all research based. Where nobody is doing a genome check to find out whether your OCT1 is active or not, or whether you are a responder or non-responder. Responder and non-responder is all found out in clinical practice. But nobody is doing this as a way of life. What I showed you on the genomics data is all in the realm of research. But it's not very far off where you see responders, non-responders. Currently, they are all part of clinical trials. All clinical trials have a small arm of genomic arm. That's also not a large arm, which is expensive for everything. But in times to come, you will have it.
Thank you, sir.
Hello, sir. I wanted to know what is the role of A1C in the Indian population? What would be the cutoffs? I mean, the HbA1c criteria are given in the ADA and all. That is it okay with the Indian population, or is there different cutoffs for it?
So first thing in India we need to do is standardize A1C. 99% of A1C in the United States is GSP compliant. So therefore, obviously, first thing we need to do in India is to have standardized labs which are NABL certified, which give us standardized A1C by a robust methodology. That's the first thing. Second thing is, once you have that, the standard reasonable goal for all non-pregnant adults is 7%. That is a standard of care. Only in limited cases you can have 6.5 as a goal, where you have a long life expectancy without any comorbidity. You can be a little more ambitious with younger populations. And people who have a limited life expectancy, again the level of evidence is C, and they have a short life expectancy with a lot of comorbidities, it could be 7.5. So that is a global recommendation. It is not specific for United States or for Europe. Okay, so that is a trend. Also remember, we need to individualize the care. So when we are also living in an era of technology, and we are also living in an era of continuous blood glucose monitoring technology. So obviously all these will change if we have better evidence basis for it. But currently, in the Indian context, we need to recognize that we need to have a standardized evidence. Also remember, a lot of US clinics and now that's happening in India too are having a point of care evaluation. Okay, and even that has to be NGSP compliant and has to be as standard as a lab test. So that's something which is also happening very quickly. Some of them are not very accurate. So we need to recognize that usually it has to be a laboratory which is ensured that it is delivering a A1C of quality.
And sir, what about the pre-diabetes cutoff? I mean, we say that less than 6.5 is pre-diabetes.
As I said, A1C from the Indian context currently is not recommended for diagnosis. The way it is recognized in the US, because there it is presumed that everything is accurate. Therefore, that 6 to 6.5 as a pre-diabetic cut point, which is there in the US, is a challenge in countries like India. It also challenges with hemoglobin. Remember, some parts of Western India have thalassemia, some parts of Western India have sickle cells. So obviously, we have still a population which is malaria. So obviously, the A1C values will be different. We also are an anemic country. Commonest cause of mortality in women today, even today, is anemia. And an average hemoglobin of an Indian woman, even today, is around 8.2 from the statistics. So obviously, our A1C needs to be standardized from that standpoint. So there are a lot of challenges from that standpoint in terms of standardization. But currently, most urban setups, most setups across India are getting reasonably reliable analysis.
Thank you, sir.
Thank you, sir, for your presentations. I'm Dr. Pranita, doing PhD in metabolic syndrome. I just have a one query. Every time whenever you are talking about obesity, you are talking about the BMI. What about the waist circumference, which is more important than BMI? What is the theoretical concept?
So absolutely, I did spoke waist circumference at point of 90 centimeters, 80 centimeters waist. We also have a student called Rakesh Parik, now it's getting very popular across the world, but waist height ratio. And that's also extremely important. So obviously, because we are thin fat Indians, it is not just BMI cut points, but waist circumference, waist hip circumference, waist height ratio are equally important.
And one more point, sir, about the HDL levels. What I find is it's very low in Asians. So still the cut points are that only, 40 and 50. So does it need to change anywhere for the Asians?
Why we get low HDLs is probably because we are very sedentary, but it's a subject matter of intense research. One of the reasons we are the largest, 80 million people in the world die every year of heart disease. And one of the reasons Asian Indians have the highest mortality with heart disease could be attributed to the lowest. Whether it is because of the sedentary habit which we have, or whether it is environmental pollution, we don't know. So standardization of HDL is another subject matter. Again, lipid lab standardization. So that's a separate matter of discussion on it. So yeah.
Shashank, excellent lecture. Just a quick question. Going by the IDEC criteria that you can use for pre-diabetes 5.7 to 6.4, keeping that your blood glucose targets will be normal, would you consider giving metformin in this population? Only on A1C.
I'm a lifestyle person. So if I would do an AGP or and if there are AGP graphs that were haywire, I know that Indians are, as Dr. Aman calls it, rapid malignant transformer, because from pre-diabetes they move to diabetes very fast. And I know that this guy got to an individual case, for a given individual, I might be informed, but not by 5.8, maybe at 6 or 6.2. But as I said, it has to be individual. If I see the curves which are going haywire,
if you find that there is a high risk profile the patient has for diabetes and only an A1C elevated, would that give you more confidence to start metformin?
I will not do that. I will integrate A1C with the continuous glucose monitoring, because sometimes the A1C also may not be completely reliable. Because if he's a smoker and he has a higher hemoglobin, I'm not so sure. So as I said, only an A1C will not make me dictate my treatment protocol. I will definitely have fasting, postprandial, I will definitely look at his high risk profile, look at his family history, use a multitude of factors in that individual.
Thank you.
I use an HG a lot. I think it is again a game changer, because it's looking at the way a person behaves on a weekday and weekend.
Sir, I'm Dr. Ashutosh Soja.
This will be the last question because running out of time.
I'm Dr. Ashutosh Soja from AFMC Pune. I personally feel that we have got a large curve under the thing, and we are very sparingly use the alpha glucosidase inhibitors. I believe, sir, with your slides and a lot of advocacy coming, we must improve that in our clinical practice. Because when many times we send the patients to the higher institution, they come with that drugs. What is your general take about the current trends as the physicians are adopting, which is the cases which are coming for you for consultation, sir?
So you are absolutely right. That we have larger postprandial curves and excursions, and that is all linked to diet. First they need to do is correct as high carb diet, and they need to go on long acting or low carbs as well. If they can't moderate, then definitely AGI is good. We are now chasing behind all these high-end drugs and forgetting some of our old drugs. So I think that we need to balance the two, and we move into combination therapy, which is good, but I think sometimes we need to be a little more rational. We use very little GLP-1 analogs, for example, in India, which we need to use much more. We use lower use of AGIs, which we need to use much more. So we are absolutely right. We need to titrate and be a little more aggressive, but also remember, we are very poor at lifestyle recommendations. And a lot of these things can be modified by just cutting the carb, reducing the food, just making the breakfast, lunch, and dinner half, just quantum control. Because we eat fast and we eat too much. If we just do that little change and do a physical activity of maybe 45 minutes every day to an hour every day, I think we can make a lot of difference in the treatment response. And often we forget that and we move into an additional drug, which is not fair.
Thank you, Shashank. Thank you very much, and thank you, audience, for the wonderful interaction. We now quickly move